important, urgent conversation about how and why we need to focus on severe mental illness, as well as the wider mental health agenda. This is an important conversation with some difficult issues, and we have the most brilliant panellists to help us consider this problem. And we're really grateful to Berger Ingelheim for sponsoring this event. Just to say, it's been independently programmed, and we've really thought about the people we've got here to bring the expertise. But one of the things that I realised when we were setting out to do this was that we didn't have anyone with lived experience on the panel, specifically invited to talk from lived experience. So what I'm going to do is introduce our panellists, and then I'm going to read from someone with lived experience, just to put that at the kind of top of the agenda. And then each of our panellists is going to talk for a bit. We're going to have a wider conversation. I'm really keen to bring in members of the audience as well. So starting on my right, we've got Paulette Hamilton MP, a former member of the Health and Social Care Select Committee. Welcome, Paulette. We've got Brian Dow, the Chief Executive of Mental Health UK and Deputy Chief Executive of Rethink Mental Illness. And we've got Luciana Berger, who's here in her capacity as chair of the Maternal Mental Health Alliance charity, and she's also been doing a review of mental health and prevention for the Labour Party. So thank you so much. Apologies from Lord Victor Adebowale, who has COVID. Oh. So, you know, just one of those unavoidable things, but he sent apologies. He would have really liked to have been here. So I'm just going to start by reading a couple of paragraphs from a piece that I go back to and read on a really regular basis when I'm thinking about this problem. It's by a Guardian journalist called Hannah Jane Parkinson, who has written very openly about her mental health illnesses. So she writes, "In recent years, the discussion around mental health has hit the mainstream. I call it the conversation. The conversation is dominated by positivity and mimification of a battle won. It isn't a bad thing that we're all talking more about mental health. It would be silly to argue otherwise. But this does not mean it's not infuriating to come home from a secure hospital, suicidal, to a bunch of celebrity awareness-raising selfies and thousands of people saying that all you need to do is ask for help, when you've been asking for help and not getting it. There is a poster in my local pharmacy that explains mental health can be complex. Getting help doesn't have to be. Each time I see it, I want to scream." She continues, we should normalise the importance of good mental health and well-being, of course. Normalise how important it is to look after oneself, eat well, socialise, exercise, and how beneficial it can and should be to talk and ask for help. But don't conflate poor mental health with mental illness, even if one can lead to the other. One can have a mental illness and good mental health, and vice versa. So what Hannah Jane writes about is the difference between mental health and mental illness, and that's what we're really discussing today, and how we deal with these sometimes competing agendas in our public services. So just with that in our mind, I'm going to each of the panelists for some opening remarks on this really important subject and stuff.
Right, let me start by saying I am really delighted to be here. A little bit about me, because it will give a context to why I'm so interested in this subject. I was trained as a general nurse and hadn't had much experience of mental health. Then in 2012, a very young cousin of mine committed suicide. Out of the blue, she was at home with mom. She wasn't well. She was living at home with her mom, and we knew that her mental health wasn't very good. The month before she died, she said, "Auntie Paulette, would you help me to find some volunteer work?" It was in the January, and I said to her, "Of course I will." Within 2 weeks, she was gone. She collected the shopping, and to cut a long story short, she then hung herself at the end of a bed, bunk bed. Then I felt really guilty. That's when I went down the road of becoming coming from novice to expert, in my humble opinion. So I then became the mental health champion for Birmingham. It was like a dog with a bone, because I couldn't understand why, at the time I'd got a pull shoulder, and if I'd got a pull shoulder, I could sort that out quite easily. But people with mental health just get hitting barriers after barriers after barriers. Also, as a local councillor, which I also was at the time, what was happening was people were blocking off streets because within the ethnic minority community, they didn't recognise mental health as mental health, and they would hide it within the families. If you live within certain communities, Asian communities, they haven't even got a word for mental health. So I saw mental health at the peak phase. So I became the mental health champion. From there, I then became, they call them lay managers, which I've been doing now for over 10 years. So I actually go into section hearings and see what people are going through. With all of that in mind, what I felt was, and what I've seen through my journey, is the breakages in the system. Without good mental health, you have no health. That saying is so true. You have young people that are going through the system since COVID, which I led through the work I did in Birmingham as a Cabinet Member for Health and Social Care. We saw young people's mental health absolutely plummet. The services weren't joined up. They didn't seem to be working with anybody else, any other services. I also found that the finances weren't within mental health. It wasn't taken as seriously as the royal family have really helped, but it seems to have gone off the boil again. The 10-year plan is an issue, because since that went, it didn't seem to have a direction and focus, and people who are living with mental health feel that the rest of society don't really care about what they're going through. So with my journey, what I've been able to see is that we need to join up the services, which Labour has talked about in its policies. We need more trained people, not necessarily nurses, but people at every level that can support people to deal with their mental health issues. And the third one, and this is a personal view, you don't have to be a qualified nurse or doctor to support someone with mental health. People need to know how to access services before they commit suicide. And this is where sometimes there is a breakdown, and it is a postcode lottery. I'll stop there, but as you can see, that was my journey. Thank you for that.
Thank you so much, and for sharing your experience of this as well. I can feel the personal motivation there. Brian, do you want to go next?
Sure, thank you very much. It's lovely to be here. And actually, I'm going to bring a bit of experience into the conversation as well, if I can. So, I mean, I suppose if the exam question is, how do we prioritise, and indeed should we be prioritising severe mental illness in the health system? And I think, firstly, the answer to that lies in the big shift that Wes is proposing that we have in the health system, the health and social care system. So, to remind people, from treatment to prevention, from hospital to community, and from analog to digital. That is, I think, the answer to how you get there. And I mean, I guess I know this partly because I've been in this job for 10 years, working very much on the kind of coalface with people who have severe mental illness. But we also draw a distinction. We talk not just about people with severe mental illness, because you can have a severe mental illness and live a fairly well, fairly positive life. You can flourish well, you can work, you can do all the things that other people can do if you get the right kind of support at the right time, close to home, quickly, and that's good quality support. But if you don't, and you might even have a less severe condition, you end up severely affected by that condition. And I guess I know it's partly as a professional, but partly through my own lived experience of my partner, who has lived with a mental illness pretty much all of her adult life. Now, I'm supposed to, I come here invited here today, a person of some level of minor influence in the health system, and I fundamentally have really struggled to get her the support that she has needed. And to cut a very long, very difficult story over the last 10 years, relatively short, she actually ended up in a secure unit at the end of October last year. And for anybody who's ever been in a secure unit, they are really pretty dreadful places. It's a locked place. She only managed to avoid being sectioned, really, because I kind of know the system quite well, and a bit like you talking yourself, Paulette, I knew how systemic it would be for her to be sectioned. So she ended up in this really appalling place. And there was a huge amount of compassion from the people running it, but they were not in a position to deliver good quality care, because what they are doing is trying to keep people safe. And it's a classic story of failure, because actually she could have been given the support she needed in primary care. She could have been given the medication that she had to go all the way into secure care unit to get to keep her well. The things that were starting to happen in her life, including family members who take their own lives, she could have got support for that. And of course, that's a classic example of, if you don't do the care quickly and you don't intervene effectively, you end up spending much more, not just in terms of the effect on that person's life, but actually the cost of the system. Is much more expensive to have somebody in secure care unit for a week than it is to be getting good treatment from the GP. And frankly, I still feel very angry at her GP. It's a big South London GP. It's got a kind of large and diverse population, but there is not a single, and there still isn't, as far as I understand it, a single mental health specialist. Now, you're not telling me, back to your point, man, you're not telling me that in that community there are not people with very severe mental health problems. So, look, going back to Wes's stress, treatment to prevention. We need to invest in research. We need to get better at diagnosing people with mental illness much more quickly. We need to develop better treatment regimes so that people are not stuck on second-grade medications for a long time. We need to make sure that they do that not just because it helps in terms of their health journey, but also, let's think about where Labour are very much focused at the moment in terms of the growth agenda. If people are spending a long time receiving treatment, they are not getting better, they're not going to be working, they're not going to be economically productive, and that's bad in terms of the wider economy. Hospitals community. Clearly, that process of moving healthcare from the right down to the left is a good thing, but we need GPs to make sure that they are getting involved in terms of the finances, but of course we can't also expect GPs to be doing an assessment of people's broader needs. So roles like navigators who can help people move around the system are very important. Labour is committed to an extra 8,500 staff, so let's see that that's going to diverse broader range of people supporting primary care, and the huge role of the voluntary sector. And we're doing some work down in Somerset, for example, and just by working with the community to develop our local health system that meets the needs of that population, we're starting to see 16% year-on-year reductions in access to AD. That's really significant numbers. And then lastly, that analog to digital. Absolutely. Yes, we can have innovative treatments in terms of AI, early detection, better gene mapping, obviously is going to help. There's some interesting work going on in terms of some companies around the Mental Health Act. A company called Thalmos are doing some really intriguing work in bringing together the different forms of support and intel that you need to move people in the system at risk of being sectioned. So lots of innovation. I guess I would probably add a fourth, which is to move from that sort of patrician care delivered to people to much more participation in the way that they receive care. And that's why third, I think, is incredibly important, because all of the factors that affect people's mental illness, their housing, their financial situation, how isolated they are, have a huge impact on their journey, that we have a cross-cutting approach to mental health, and that's why I'm very much looking forward to being involved in this.
Brian, thank you so much.
Thank you so much. I'm not sure if this is working. This is working. Can you hear me? Okay. Thank you so much. I'm so glad that we are having this panel. If I reflect on previous conferences, I can't recall. I'm sure there have been a panel too, but certainly having a specific conversation that's dedicated to SMI, serious mental illness, I think is really important, because it's often the element that we don't talk about enough. And particularly the fact that I think that already you've heard from everyone who has had the session informed by lived experience and heard from someone with experience is really important as well. Certainly we should be doing that with everything that comes to mental health. And I just echo what Polly said, that it's urgent as well. And it's great to see so many people in this room. And I should just add that please forgive me that I have to leave 10 minutes before the end. And if I do miss any contributions and people need to know what they are, please do share them via social media or email, because I think this conversation is so very important. I suppose the lived experience that I bring to this is that I grew up with an immediate family member who was in and out of inpatient mental health services, And I think it's fair to say that those, the style and delivery of those services hasn't evolved as much as they should have done compared to the rest of the health service. There are too many services in this country that are just managing risk. They're not providing therapeutic care. They're very transactional, and it's rather than relational. And it's more about kind of how to make sure that we're containing and/or trying to do our best to reduce suicide rather than look at and deal and support the individual whole person. And so it is a very timely, important question. I think we have to go back to basics, and we have that opportunity with this government. I think in part because SNI, the very people whose voices we should be listening to, for many good reasons, can't be in the spaces or aren't in the rooms. Well, we've got to do even more to compensate for that. And I do think we have got a very receptive new government. You'd expect me to say that as a former Labour MP, but this is a massive opportunity. And I was going to come on to opportunities at the end, but perhaps it's relevant at this moment. We are going to have a new Mental Health Act in this country, and if there's anything that we can say that particularly for this group of people who have disproportionately been let down and disadvantaged, I think this is where we can make a difference to on the journey. It's not going to be a panacea. And I suppose for anyone in this room that's interested, there's not going to be an opportunity over the coming weeks and months to contribute, and I'd urge everyone to do so. If you've got something to say, I was involved in the very first conversations about having a new Mental Health Act back in 2015. It's extraordinary it's taken us this long to get to where we are, but I still don't think we've got it quite right. Obviously, we've had the pre-legislative scrutiny committees that have looked at the legislation. There are still some bits that need to be amended, and any expertise in this room, either via your work, day-to-day work or your lived experience, are going to be important to make sure we get the right legislation. And while it's been announced, it's going to come forward, we need to get it right, because I think we've got it, some elements of it very wrong, certainly, or we haven't kept pace with right-wing changes in society to look after this group of people. I don't want to focus too much on my other fellow fantastic panelists have shared where we're at. It is a serious situation. We have seen acuity rising. I've just come to the end of doing this mental health review. While I've first and foremost focused on prevention, I'm really struck by some of the conversations I've had, and I don't think I will ever forget the conversation I had with a psychiatrist who'd just come off shift in a hospital in an A&E ward, to hear that just how bad things are. We've got people waiting in A&E for 48 hours plus, and that's not the right place for them. They're in mental health crisis, and they're often told to go home or just not cared for over weekends. We have a responsibility, and we've got to meet that responsibility. We can't do nothing now. I was with the chief executive of a mental health trust yesterday, and he was saying, we're only meeting 30% of need amongst children and young people, to Paulette's point. That's 70% of children and young people whose need we're not meeting. We're storing up morbidity, we're storing up crises to come down. I think that's going to be, and certainly is a concern of West Streeting and the health team today. But there are opportunities, and it's not just the mental health. I don't want to kind of conclude my remarks on kind of where the future lies and the opportunities lie. I think certainly having a shift to prevention is important, although we must never forget, and I'm not suggesting for 1 second you are, Brian, knowing all the amazing work that you do, but many people, we can't prevent every episode of serious mental illness. And we can do so much more to prevent so much more, but actually probably for this group of people, we'll first and foremost need to be thinking about early intervention. But it's both sides of the coin. Just down the road, there's been a new unit just opened called Aspenwood. That is, I think, a really great example of bringing together. It's a low secure unit. Also, people at the intersection of people with mental health and learning disabilities. I think shows us where the future lies and what good services can look like. That's what we should be aspiring to for all services in this country. And there's also plans in this region to open the first mental health digital research centre, and if it is successful, it'll be the first in Europe. And when we talk about how we can affect change for all groups, but including people with serious mental illness, these are the very things that we should be harnessing, and it's really exciting to hear that we're on that journey. We're certainly behind the curve. We know that research, funding for research in mental health is so far behind funding for research in physical health, and we've got to work to close that gap. But I'm very positive about some of the things that are coming down the line.
fantastic. Thanks. So I'd just like to say thank you to those open scene setting. I'm going to come straight back to you and Paulette, if that's okay, but just because we know we're losing both of you at 10 to. So
That's a big call on me for
yeah, I know. I've got a whole 10 minutes.
I'm a good song and dance.
I wanted to go back to the first thing you said, actually, about there not being therapeutic services in secure settings. Because I don't think people really know that, and that idea of that there not being enough therapeutic services, and actually some secure centres really being about kind of managing rather than helping. Not for want of the teams, but...
Or there is some level of therapeutic provision. But if you look at over the course of an entire week where someone will be in an inpatient setting, it's like a couple of hours if that. And otherwise, it's like, how can we make sure you're not going to attempt to take your life in your room, or maybe we'll give you some outdoor space where there's very little activity and engagement and the social connection as well, which we know from research can make such a difference. So, it's not anyone's fault. I know that so many mental health trusts, have the best intentions. I mean, they've been cut to the bone, and they don't have, they're trying to contend with, now when you speak to many chief executives of mental health trusts across the country, we're at a moment today that we've never been at, I don't think, where there's literally at any one day at least 50 people in any area that, are either waiting to be discharged and being essentially held in units because there's nowhere to put them. We don't have enough step-down care, we don't have enough appropriate accommodation, we don't have safe places for people to go to, or there aren't the beds in the first place, so people that are being held, I say held because it often is held, either in section 106 spaces, if we can call them that, people that, are in A&E units or urgent care units or just regular units in a hospital, or they live a unit with nothing to do with what they're experiencing, and no one who's properly or adequately trained to support them at their moment of crisis. I mean, we just need to look at the whole thing to make it 10 times better.
Yeah, and just tell us briefly what Aspen Wood is doing that's different.
Oh, well, I think because it's led by a trust that has research at its core. There's very sound and robust evidence that shows if you're leading with the research alongside the care that you're providing, then the two go hand in hand, be complementary and do better things. I think it's a very forward-looking trust. I'm not seeking to do down all trust because again I totally acknowledge and accept the severely constrained environments in which they operate and the immense pressures that they're under. I think I was an MP in the area, and I kind of saw that I think there's a number of trusts that have tried even harder and have also leveraged in. I think the difference is, for example, for Mercy Care in this region, they've leveraged in a lot of investment from the private sector. They've also been in receipt of significant research funds, which have helped to offset or to actually pay for NHS services. So they've had to be very creative and have done so. They shouldn't have had to do that, and that's why they've perhaps had additional space to do better things. And they've also worked really, really hard on partnerships. They work very, very closely with the combined authority, with the local authority, or the adjacent councils, again, to share resources, not duplicate efforts, to make it everyone's endeavour. There's lots of different things, but it's not to criticise other trusts.
Of course, yeah. Of course. And with your review, just because a couple of people were saying, where's it at? What's the status? And
so I'm obviously delighted to be participating in this discussion, which is so important. It's worth saying from the very beginning that my review has not looked at services. So in the context of this conversation, it's not directly relevant. It's already 50,000 words, and it's just about prevention and how we keep people well in our communities and in our workspaces and in our colleges, nurseries, universities and schools. So just to manage everyone's expectations is not looking at, and I certainly make the point that this is a group of people which I don't think are properly or adequately addressed in this review because it's not in my terms of reference.
Yeah.
So I'm going to actually kind of refresh it slightly because I've had the privilege of joining a number of these conversations over the last few days. I'm going to sprinkle in and add quite a few additional new nuggets. A few reports have just come out in recent weeks that are also relevant to the review. I was with West Street yesterday, so unclear of the exact timetable, but there will be some outing of the review in the coming months.
That's fantastic. That's really great to hear. Thank you so much. Paulette, I want to pick up on what you were saying about, as we're kind of thinking about the state of services for people with severe mental illnesses. You mentioned postcode lottery and the kind of differences across the country. What have you seen of that?
Well, as someone that has actually done quite a lot of work in this area, some areas are really quite well organised. Areas like Birmingham, and I will highlight Birmingham because I know it so well. You can live in Birmingham and you struggle to get services. You talked about the therapeutic services. For me, it would be better if we could offer it on a wider scale in the community. The problem we're having there is our third sector organisations which support the work that is being done by the acute setting. Because of the way commissioning is done, funding is being cut regularly, they're not able to offer the services across the piece the way that they used to. So it means that even though they're willing to do it, they're struggling to do it. So it means where we could support people with therapeutic services, it is a postcode lottery. It just depends on how much funding is there at that moment in time. And it also, what has been going on is the funding has been cut quite at short notice. They've not been able to carry on with the services. And what we need is to really look, and I know Luciana hasn't been looking at that, but commissioning is an issue here. Because if you're not commissioning the services evenly, and you don't get that even spread, it does then bring that postcode lottery. Also, when you have people who are stuck in hospital and they're ready to come out, some of the biggest issues around housing, housing support, how do you get them the support to live in the community in an independent way? And many people are stuck in the hospital setting for a lot longer than they need to be, simply because the services aren't joined up. And many of them, when it comes to them being like them leaving hospital, the problem that is happening in that front is that when they decide, the doctors say, well, this person is almost ready to leave hospital, that's when they start looking for like somewhere for them to live and what have you. That can take a further 6 months, sometimes a year, because the settings are just not suitable, or where they need to be, it is not ready for them. So for me, if we're looking at this system as holistic, we have to look at bringing in other areas. So it cannot be looked at in isolation. It has to be looked at in the realms of what is their housing like? What is the support when they're going into the community? Where are they going to go? We want them to have a normal life. How are we going to help them to do that? So the area that we put them to live, are they going to be isolated because they've got no family contact? They've got nobody around them to help support them? Because remember, many of us in this room live with mental health issues, but it's how it's managed. And sometimes, unfortunately, you do need that hospital stay. And I have got nothing against that. But it's when you then become institutionalized because you go into hospital and you can't come out. Prevention shouldn't be at the risk of what is then happening in the acute setting. It should all be evenly spread. I absolutely believe prevention is better than cure. But what I also believe, if we're going into the prevention realm, we need to put the resources in the prevention realm, where we're working with both the voluntary sector, we're working with the councils, we're working with mental health, we're working with the mayors, so that it isn't just being done in a piecemeal manner. I absolutely agree with some of what the government is saying regarding give coroners more power to access information held by technology companies after a child's death. I absolutely agree with all of that, but it's the how for me. How would my cousin have not died in that system if she'd got more support? The thing was, she was left with her mom to cope with her. Mom had to work, couldn't be at home with her every day. And so mom didn't realize that she was accessing information. I'm sorry if some of you have been through this, that said, what happens after I die? And mom finds this after she's gone, and she plans her own death, but does it privately. If there was some help when she was crying out that she needed people around her, she needed to go to, when she asked me if she could get some voluntary work, perhaps that would have stopped her from taking her own life. And finally, the work that I do as a lay manager is just valuable, because what it is showing you is why do some people survive with mental health issues. Some people actually take their own lives, and some people become institutionalized, and it is all the same. It just seems to be the same route that certain people are taking. And the example I'm going to show you, and all of you know, 1 in 4 men from the African Caribbean community are more likely to be in the mental health system, locked up in hospital, because they are accessed at a later date. And that's why what you said about the doctor and the fact that they are key, the GPs, and the surgery and the support that's given there is key. Many of the grandmothers out there, the issue they have is, especially in the African and Caribbean community, it's a bit of shame. They think, well, where did we go wrong? And they try to hide it. Even though it's getting better, it's still not where it needs to be, because mental health, and this is my opinion, you can shout me down, it's still not considered as an even and the same level as physical health. So people still, even though it's getting better, are still trying to hide when their loved one has got a mental health issue until it explodes. And I'll stop there. I could go on forever. I'm terrible. Sorry.
I can listen forever. Particularly, I mean, what I'm hearing in that is just the kind of the wrongness of a system so kind of defunded that it's focusing on that acute end and creating bigger and bigger problems, and that the case for prevention is so strong. And your question of how you make that shift feels really fundamental to this conversation. Brian, I'm really keen to pick up on what you were saying about research and better treatment and what the government can do to support all of that. But would you mind if we did a few questions from the audience first, just while we sort
that'll give my time to think of the answer.
Yeah. So I'd like to take kind of 3 questions. Dan's going to come around with the mic. I'm going to make it easy and take the 3 hands that are up in the aisle for the panelists. And if you can introduce yourself, that'd be great.
I just shout. So I'm Yogi Lin, day job as a lawyer, and question really is about people in units, so not prevention. One example I give, in the last year I went to a unit and saw a guy who'd been in there for over a year before, sorry, been there years, but for 12 months before I visited, the doctors had agreed he was fit for discharge. And why was he in there for 12 months when he's fit for discharge? It was only, I think, a month before I arrived that he was on the doles, deprivation of liberty, so I was instructed to act for him, and then within 6 weeks he's out. I see him, everybody jumps on the unit, the discharge manager puts his head in shame because he knows that he's not been able to organise a placement. So why does it take so long? So that's an example of just the question of why early advocacy and advice is not provided to someone who's ready to discharge.
Thank you.
Can people hear me? Because I swallowed my voice, I've been told.
Oh, there you are. I can hear you.
So, okay, so I'm an RMN, I started my career when the old institution's been closed. So I now work in primary care on the SMI register doing QOF. So I've seen a lot of changes, and I think there's been some really good practice. You know, there's been some highlights when we had care in the community, it was properly funded. We had assertive outreach, properly funded. To a degree, we've still got early intervention in psychosis, but the trust I work for now wants to close assertive outreach because it's too expensive. The trust I worked for before, I've seen people searching through bins for food that were well supported by assertive outreach who no longer exist. I've also worked for the iNHouse service as well, so that's another kind of innovation, I guess, but that's at the other end of the scale. But I suppose my point is really that the sure start stuff at the very beginning where you get parents and children. I've seen that work really well in Corby. They're just about hanging on.
Yeah.
You know.
And sorry, what was your name?
Sarah, sorry.
Sarah. Thank you, Sarah. And
Thank you. Sorry, can you hear me? Yes. Well, my name is Alvaro Berger. I'm a consultant psychiatrist. I've been a consultant psychiatrist for more than 20 years. So I can remember clearly what the difference that the previous Labour government made in terms of investment and development of services. And I witnessed for 14 years the destruction of services. Sorry, I know what happened. Can you hear me now? The destruction of services. Each year, a degradation of this or that or this or that. You know? So I'll give you a couple of the data. Early 1990s, there were 70,000 deaths for mental health care. Royal College of Psychiatrists published a report in 2019. There are 18,000 deaths. Without, you can calculate, without taking into account the growth of the population. So when I was working in 2004, we had the full community mental health team with CPNs, psychologists, social workers, occupational therapists. Now, there are places where patients who are discharged from hospital or are in the community are in a waiting list to have a care coordinator in the community.
Yeah.
Not 1 week, 2 weeks, months. Someone who is, I'm talking about severe mental illness. That's what I do every day. I see people with severe mental illness, not mild, not immediate, you know, I see the severe end of the spectrum. And people who are at risk of suicide, people who are at risk of neglecting the children, people who are at risk of being exploited or are being exploited, like drug dealers, etc.
do you have, this is such an interesting experience. Do you have a question?
Yeah, sorry. So I was
Thank
introduction
you.
to the question.
Thank you.
One of the things I think is, I wonder whether you see it as an important issue to one. You think that community mental health teams should be redeveloped, reinforced? Is there an issue to do with staff, workforce, and skill mix? I think that would make a significant change. And the second one is that I don't know how many people are aware here that over the last 20 years in psychiatry and mental health care, we had the care program approach, or CPA, which was the framework to provide care, joint up care. And that has been, last year, the government, or the year before last, the government, the Conservative government said that that's the end of it. We don't have that. And I think something that the new Labour government could do is to say, look, let's go back to the way in which we used to work.
I also think next year we should have you three on a panel because you've just covered all the experience, the lawyer, the mental health nurse, and psychiatrist. So absolutely brilliant.
Joke, doesn't it?
Yeah. Brian, do you want to take the first question and then I'll broaden it out to others on the second two?
Yeah, I mean, I'll be fairly brief, but I'll hopefully cover all three in my kind of answer. So, I mean, firstly, the case for hope, which I think was around your point. I mean, I think it is really important to hold on to hope in both progress that was made in the past, but also progress that was made. And this is not necessarily going to go down brilliantly with this audience, but over the course of 2010 to 2017, the reality was that there was quite a lot of progress. We had the 5-year forward view on mental health, that became the long-term plan, and if you look at a lot of the indices, they were gradually starting to improve. Now, I'm not suggesting that the previous coalition government or the Conservative government were first to think about this or to do something, but there was quite a lot of progress that was made over that period of time, and it has gone very much backwards since the pandemic. But I think it sort of builds us to the point that the first question kind of addressed, and I think both Paulette and Luciana talked about, which is just this notion of pressure building in the system, because it goes without saying, if you don't intervene effectively quickly, then regardless of the severity or the acuity of somebody's illness, they're almost certainly likely to get worse, and then depend on higher intense use services. And then that comes out the other side. So you get the pressure coming into the system, and then people get stuck in the system because, of course, there's nowhere to step down when they are ready, actually, in reality, to move back down to social care, because social care has been decimated over the last 12, 13 years. And I think then that brings us to the last point around community mental health, which is, I mean, absolutely, the vast majority of people should be getting their care, even if they have a severe mental illness, in the community. And I didn't finish the second half of my story about my partner. She's much, much, much better. But the community mental health team is really struggling. And she's really struggling to get access to the appointment. So I think if we take a much more system-wide approach to it and retain that case for hope and build public mandate for it, I think we can solve a huge number of these problems that currently feel absolutely existential.
Thank you. And Luciana?
Yes, I mean, obviously we have like further evidence to kind of corroborate what I think collectively we probably all know is a situation where the service and the sector is not being served well, and first and foremost, patients are not being served well by any stretch. So I'm keen obviously to kind of focus on what we can and should be doing to address that, and certainly again to the first point from Yogi about what's happening with people that are in inpatient care unnecessarily. I hope that the new Mental Health Act will go some way to address that and making sure that everyone has an advocate and has someone that can be their voice, and if they're not able to advocate on behalf of themselves, and that's going to be very, very important. But obviously it also requires the investment, as we've kind of touched on already, to ensure that there is, whether it's the homes or the accommodation or the support or the step down or adequate step down care, to provide that in the community for people to actually be looked after afterwards as well. I just wanted to connect perhaps Sarah and Alvaro's points. Sarah, your point about starting with parents and children. In my role as the chair of the Maternal Mental Health Alliance, we look at everything that we can and should be doing from the perinatal period, starting in pregnancy, and actually we should be thinking about before conception. Absolutely, we can and should be doing so much more, because we know so much of this stems from what happens in the first 1,001 days and what happens during the 0 to 5 year period. Again, just to reinforce the point, we can't prevent every episode of serious mental illness, but certainly can go a long way to reduce the levels of trauma experienced, particularly by children and young people under 5s that don't get any support whatsoever. I'm heartened by the campaign we've run at the Alliance over the course of the past 10 years. It ensures now for the first time in all 4 corners of the United Kingdom, we do have mother and baby units for women that experience episodes of psychosis or other serious mental illness in the year after birth, to ensure that they're kept together with their babies, because we know how important that is for both babies and the mothers and for family and for development. But that's only the first part of the story. So the next frontier for us that we're working really hard on is about that provision of support and care in the community, because of course not every woman that experiences perinatal mental illness will require inpatient support, but they will require good support, joined up support in the community. And that brings the work that is so important, bringing together midwives and health visitors and GPs and specialists. And we're seeing some progress. We've got some new services now that are providing support to women that either experience fear of pregnancy, who have birth trauma, who are separated from their children, which again has far-reaching and long-term mental health consequences for both mother and baby. But we've still got a long way to go. So that community care is absolutely crucial. But I feel positive that I think the future's going to get brighter. We are going to do so much more to support those women at that time.
Thank you. And Paulette,
I just want to answer the question about the 70,000 beds being reduced to 18,000. Can I say to you, as a lay manager, we found this really difficult to cope with at first, because many people were then coming into the services when they were at a deeper acute stage because they couldn't get a bed. But I do still think this is the right way to go. I know consultants and hospital staff will not agree with that, but my argument is if we're truly going to push things to the preventative stage where people can be dealt with in the community, we need to strengthen the community services, we need to ensure the third sector are there, ready, financed to do their role. We need to ensure that local councils are funded so that when they're called upon to supply accommodation and what have you, it's done, so that people aren't then struggling to get to their GPs and other services that they need, to the extent where they become so acute they then have to go into hospital and they're there for a lot longer, because that's what we're seeing at the moment, and that's what we need to stop. And that's why I actually support and believe that this government, our government, really does believe in prevention. And if we're truly talking about prevention, we cannot then go back to having the large numbers of beds we had before, because it really isn't solving a long-term problem. So
Thank you for that very nuanced view. I'm going to let two of our colleagues
Oh,
go and say thank you so much for joining us. Continue the conversation. We're going to come back to that R&D point around developing treatments and better services, and then I'm keen to open it up to more discussion with the audience. We've already heard what incredible expertise we have in the audience as well. So just Brian, on that point around R&D for better treatment.
Yeah, it's I think Paulette mentioned it in her remarks. There was a huge gap between the level of research that's going into diagnostics and treatments in terms of mental health versus physical health. Now, it's not a fair comparison because, of course, when we talk about physical health, we're talking about a myriad of different conditions. But, different times researchers said that the mental health, forgive me, burden is about, I think, 23% of the total health cost. And the research level that's going into it's nothing like that. However, things are changing. Wellcome's doing a lot of work to lead a big programme of research, along with many others in the sector. We actually recently convened a round table, and I think Marty, who's the president of the Royal College of Psychiatrists, was at it. It's brilliant as always, and if he gets stuck on stage, he can always come up and join me. And I think the message that emerged from that is if we can make sure that process is led by people who experience severe mental illness, then we are far likely to get to ultimately kind of program of research that does meet the needs that are out there. So I think there is I think case for being optimistic about the fact that that's beginning to change. But it's a long
What
way
can the
back.
government do to support more investment in that area?
Well, I mean, I think there's a number of things I think it could do. I mean, firstly, it can send a political signal that the investment in research is important, that clearly those who are working in research, whether it's academics or whether it's pharmaceutical companies or others, that they will be rewarded with the funding to do that. There will be security. I think the government can also demonstrate that in terms of the NHS itself, the need is there. There's no doubt people in this audience who are on the front line of the health system themselves who will be experiencing the effect of that lack of research in terms of the secondary treatments they are forced to give to people, and the sort of general lack of early intervention that's effective.
Yeah, brilliant. What I'd like to do in the last we've got 7 minutes left together. What I'd like to do is perhaps take 3 contributions from the audience, and in a radical departure from all that is normal about these things, I would love to hear your views as well as your questions. I'd like to hear from each other. So, lady in the middle here, Kathy on the left there, and there.
Hi, I'm Maddie Smith. I'm actually president of the Royal College of Psychiatrists. And thank you for holding this event. Sorry for late. But a couple of things. Number one, actually, people with severe mental illness, as I've heard described, really do have the worst outcomes in our country of most health disorders. And that's because not only do they have comorbid physical health problems, they're the people who are most likely to be subject to inequality, poverty, and the impact of that. So literally, the severe mental illness makes you poor, and the poverty makes your illness worse. And that inequality is writ large, and it's particularly bad for people from racialised minorities. And I think we've talked about that probably already. The concern is this, that there's an idea somehow that as long as you can prevent these things, and actually you're not going to prevent all mental illness, then, I mean, Paulette just said there that, you know, you probably don't need beds. That's not true. You have to understand that we used to have 154,000 beds, we now have 17,500 beds. Now, we know that across the country, there are some places where they only need 70% of their bed occupancy, but there are other places that there's 130% bed occupancy. And it's not just severe mental illnesses, it's people who have severe severity of illness. And it is partly to do with the lack of community services, but even if you have fantastic, brilliant community mental health services, some people are still going to need beds.
Yeah. And to reassure you, and Luciana made that point kind of quite clearly as well.
And the other point really is to say that, and this is I have realised since doing this role, and doing it for just over a year, that there is a structural discrimination against people with mental illness. And the way we know that is because there's clear need, but nothing's being done about it. And the reason nothing's being done about it is because, well, it's people with mental illness. Do they vote? Do we care? And sometimes it's not just that our patients are hard to reach, they are just simply easy to forget. If people don't know someone who's got that problem, then they don't even think about it. And then there's a fallacy that somehow people can pull themselves together. There's actually a whole anti-psychiatry movement. There isn't an anti-cardiology movement. There isn't an anti-nephrology movement. But for some reason, it's okay to be anti-psychiatry. And what that does is it completely negates people who have severe mental health problems because they won't get help because it's thought, well, you know, these things aren't real. There was even an article in the Telegraph last week essentially saying this stuff is just that somehow it's a con. And until we change that narrative and until we change that discrimination, our patients are going to continue having the worst outcomes and the worst practice.
Thank you so much for that contribution.
Hi, I'm chief exec of a charity called Family Rights Group, and we work with families whose children are involved with children's social care. But I also have, as I bet everybody in the room does, personal experience in relation to my best friend's daughter's been sectioned now for nearly 2 years, and during that time, no therapeutic support. It is containment, and it's also that isolation and loneliness. And she's in Manchester, they're in London. If you know, they're financially fortunate, but it is hellish. And for most families, it's just the system pushes them away. And I just wanted to raise, as you'll be aware, there's been a big increase in the number of deprivation of liberty orders for young people. And unlike if a child's subject to a care order, if it's deprivation of liberty order, the parents do not have automatic legal aid. So the whole system pushes families out from the outset, and that continues. So it's both economically, but also if the family is not involved even in deprivation of liberty proceedings, then they're effectively excluded from what plans are being made for and with their child.
Kathy, thank you so much, and really shocking to hear those experiences. And at the front here.
Hi. I'm Julie Jarman. I'm a CLP rep from Rosham. I've been a non-executive director on the Mental Health Trust for 7 years, and I'm the carer of an adult daughter who has a severe mental illness. And I suspect a lot of us in this room have got direct experience, and that's why we're here. So my question for the panel had been going to be around how we can prevent criminalisation. We think for many people in the mental health system that's a fear. In our mental health trust, we saw a horrible shuttle between medium secure units and prison. So people would get better in our hospital, they would go back into prison to finish off their sentences because they were considered well enough to be there, and then they would come back from prison because of course their mental health would deteriorate in prison. But the other point that I quickly wanted to make was just, and it was agreeing with something that Paulette mentioned, this is a cross-departmental issue, and it bothers me when it sits of course, rightly in social care and health. I wanted to mention, for example, housing, obviously, but the impact of the welfare system. And this government is already making those noises about, they don't call it scroungers, but pushing people who can work back into work. And I think there's extremely limited understanding in the Department of Work and Pensions of the reality of what mental health is like. There's some slightly more understanding of conditions that vary from day to day, but there's very little. So, for example, trying to get mobility PIP for mental health purposes is extremely difficult, but my daughter certainly can't use public transport. So it's just really, the plea is for this not to become siloed into one department, but to be seen as a cross-departmental issue.
I mean, just in those 3 contributions alone, you can see the kind of complexity of these, how they stem into kind of the systemic kind of cross-society structural problems that we have, how they dig into the quality of people's families' lives and how they span the whole state's kind of impact on individuals and responsibility to individuals. So much more to learn from you all, but I'm going to ask Brian to just kind of wrap up neatly a very complicated and just really important conversation we've had.
Okay, no big task there.
No.
Well, I'll just say really quickly to those points. I mean, obviously, I completely agree with Laddie that you need the bed provision that you need, and the huge cut that we've seen just builds more pressure. So the notion that we can kind of cope with their beds, I don't know that anybody's particularly said that, but we need, it's a huge problem right there. And then there was a point around sort of assertive outreach, which, you know, we've seen in a couple of very high-profile cases has been not there, and if it had been there, it might have made a difference. And of course, that speaks to the issue of racism and so on. Criminalisation, I absolutely agree. It's a very thin end of a wedge, and if somebody's very unwell, they are at risk, and we all know this, that some people are at risk of doing harm to themselves and to others, and an improved mental health act will go some way to mediating some of those challenges.
Can I just ask colleagues to pause their conversation just until the end? Sorry, I know you're urgent, you're keen to cut, but it's quite distracting. We've got 2 more minutes, so
Okay,
Brian.
so we're 2 minutes. So, and then the last point around the benefit system. I mean, fundamentally, you need 3 things. You need a benefit system that protects those who cannot work and will be able to work. You need to have, in terms of mental health, programs that support people into work who are currently far away from work, but who could work with the right support. And then in terms of people who are in work and dropping out of work, you need to support those people who then end up unemployed and in difficulties. And we don't have that combination yet, and I'm hopeful that that argument is being heard by the DWP and others. So it is, quite right, it's a cross-governmental issue. I mean, I suppose I would say 2 things by way of summary. We have consistently heard from all panelists and all the questions that the pressure in the system is creating problems in lots of other, in all parts of it. And unless we can recognise that none of this exists on its own, whether it's those people who will always have a severe mental illness, will always need to be potentially even detained, right through to those whose health could be improved if we get early and effective treatment. Unless we see it as a kind of system challenge, then I think we will fail. But the second point, I think, in the other direction is the case for hope, because progress is possible. I think there is a public mandate. We've seen from the work that More Uncommon did with us, for example, that almost all strata societies think there is a mental health problem and support the need for change. It's not just people in this room who think that. And I personally think that's probably a bit of a driving factor in the result of the general election. I am biased to acknowledge that, but the data does seem to say that the public want and demand change. And I think as long as that's the case, you have the potential for the first thing to happen. So ultimately, even though I think there's a lot to feel very worried and anxious about, I think the conditions for change are possibly, in some senses, better than they've been for a while.
So I want to say a huge thank you to Brian, huge thank you to all of you, huge thank you to Berger and your family for a fantastic conversation that gives us so much food for thought to take into all of the work we're doing around prevention and healthcare and in our kind of influencing of the next government. So thank you very much for taking part in this really important conversation.